Welcome to this presentation on soft tissue injuries. Today, we will explore the different types of soft tissue injuries, their pathophysiology, and emergency care management. Understanding these injuries is crucial for effective pre-hospital care, ensuring patient safety and preventing complications. The primary concern in soft tissue injuries is stopping any bleeding. Once bleeding is controlled, the healing process begins with inflammation, where the body sends white blood cells and nutrients to the injured site. Next, new cells regenerate to repair the damaged tissue. Blood vessels grow to supply the area, and collagen helps stabilize and reconnect tissue layers. This complex process ensures proper wound healing and prevents infection. Closed injuries occur beneath the skin without breaking its surface. A contusion, commonly known as a bruise, results from small blood vessels breaking due to trauma. A hematoma is a more significant collection of blood within damaged tissue or body cavities. Lastly, crushing injuries occur when an extreme force is applied to the body, which can cause severe internal damage even if there is no visible wound. Crush syndrome can develop when a part of the body is trapped for more than 4 hours. In this case, damaged muscle cells begin to break down and release harmful toxins into the bloodstream. This can lead to severe complications, including kidney failure and cardiac arrest. Recognizing crush syndrome early is critical for proper pre-hospital care. Compartment syndrome is another severe consequence of closed injuries. It occurs when swelling and internal bleeding increase pressure within a muscle compartment, reducing blood flow and leading to tissue death. Without prompt recognition and treatment, this can result in permanent damage or even loss of a limb. Always assess closed injuries carefully, as underlying damage may be more serious than it appears. Open injuries involve a break in the skin, exposing underlying tissue to the environment. There are 4 main types: abrasions, lacerations, avulsions, and penetrating wounds. Each type has distinct characteristics and requires specific emergency care to prevent infection and further injury. Abrasions occur when the superficial layers of skin are scraped away by friction against a rough surface. While these wounds may not bleed heavily, they expose capillaries and increase the risk of infection. Proper wound cleaning and protection are essential to promote healing. A laceration is a jagged or irregular wound, often caused by blunt trauma. In contrast, an incision is a clean-cut wound made by a sharp object. Lacerations can extend deep into muscles, nerves, and blood vessels, increasing the risk of significant bleeding and infection. Immediate wound care is necessary to minimize complications. Avulsions occur when soft tissue is torn completely away or left hanging as a flap. These injuries often result in heavy bleeding and require immediate control of hemorrhage. Preserving avulsed tissue and keeping it clean can improve the chances of successful reattachment. Amputations involve the complete severing of a limb or body part. Immediate care includes controlling bleeding with a tourniquet if necessary and preserving the amputated part by wrapping it in sterile gauze and keeping it cool. Quick transport to a surgical facility is essential. Penetrating injuries occur when an object, such as a knife or bullet, pierces the skin. These injuries may appear minor on the surface but can cause extensive internal damage. For gunshot wounds, assessing the number of wounds and determining the type of firearm used can help gauge the severity of internal trauma. Blast injuries involve multiple types of trauma. Primary blast injuries result from the pressure wave of an explosion. Secondary injuries occur when debris strikes the victim. Tertiary injuries happen when the force of the explosion throws a person into another object. Each type requires careful assessment and management. Closed injuries can be more challenging to assess than open injuries since the damage may not be visible. When evaluating a patient, look for bruising, swelling, and deformity, and always listen to the patient's complaints of pain. A thorough assessment ensures that hidden injuries are not overlooked. Small contusions may not require special emergency care, but severe closed injuries can lead to hypovolemic shock due to internal bleeding. Monitoring the injury site closely is crucial to detect any signs of deterioration. The Rice's mnemonic helps guide treatment for closed injuries: rest, ice, compression, elevation, and splinting. These steps reduce swelling, alleviate pain, and prevent further injury. Shock can develop in patients with significant closed injuries. Watch for signs such as anxiety, altered mental status, increased heart and respiratory rates, sweating, cool skin, and low blood pressure. Recognizing these early signs can be life-saving. For open injuries, following standard precautions is critical. If life-threatening bleeding is present, assign someone to apply direct pressure immediately. Chest and abdominal wounds require occlusive dressings to prevent air from entering the body. Bleeding control is a priority. Use direct pressure and elevation first, followed by pressure dressings and splints. If these methods fail, a tourniquet may be necessary. Since all open wounds carry a risk of infection, they should be cleaned and covered properly. Even if a fracture is not suspected, splinting an injured extremity can help control bleeding and prevent further tissue damage. Abdominal wounds require special attention. If an abdominal injury exposes internal organs, this is known as an evisceration. In such cases, do not attempt to push the organs back in. Instead, cover the wound with a sterile, moist dressing and secure it with an occlusive dressing to keep the area protected. Keeping the exposed organs moist and warm is critical to prevent further complications. When dealing with impaled objects, removal is only advised in two situations: if the object is obstructing the airway or if it interferes with CPR. Otherwise, stabilize the object in place with bulky dressings and ensure minimal movement during transport. Uncontrolled removal can cause severe bleeding and further damage. Open neck injuries present a unique set of dangers, as damaged veins can allow air to enter the circulatory system, potentially leading to an air embolism. These injuries should be covered immediately with an occlusive dressing. Apply manual pressure, but be cautious not to compress both carotid arteries simultaneously, as this could restrict blood flow to the brain. Small animal bites pose a high risk of infection due to the bacteria present in the animal's mouth. Treatment includes cleaning the wound thoroughly, applying a sterile dressing, and ensuring that the patient receives appropriate care, such as tetanus prophylaxis and possibly antibiotics. More severe bites may require surgical intervention. Rabies is a significant concern with animal bites. This viral infection affects the central nervous system and can be fatal if untreated. It is transmitted through the saliva of an infected animal. If rabies exposure is suspected, the patient will require a series of special vaccinations to prevent the virus from spreading. Immediate medical evaluation is essential. Human bites are just as dangerous, if not more so, than animal bites due to the wide range of bacteria and viruses in the human mouth. Any human bite that breaks the skin should be considered a serious wound. These injuries require thorough cleaning, dressing, and medical evaluation to prevent infection. Emergency treatment for all open injuries includes applying a dry, sterile dressing, immobilizing the area when necessary, and promptly transporting the patient for further medical care. Infection control and proper wound management are crucial in preventing complications. Burn injuries are among the most painful and serious soft tissue injuries. A burn occurs when the body absorbs more radiant energy than it can handle, leading to cell damage. The most common sources include heat, toxic chemicals, and electricity. Immediate care is crucial to prevent complications such as infection and shock. Certain groups, such as children, older adults, and those with pre-existing medical conditions, are more susceptible to shock following burn injuries. A thorough assessment is needed to determine the severity and extent of the burn before initiating appropriate treatment. Burns result from the transfer of radiation, thermal, or electrical energy to the skin. Thermal burns occur when the skin is exposed to temperatures above 111 degrees Fahrenheit. The severity of a burn depends on multiple factors, including temperature, concentration, amount of heat exposure, and duration of contact. The depth of a burn correlates with the intensity of heat exposure. First-degree burns affect only the outer layer of skin. Second-degree burns extend into the dermis, causing blistering. Third-degree burns penetrate all layers of skin, often affecting underlying muscle and bone. In cases of severe burns, the body's ability to limit heat exposure is compromised, particularly if the victim is unconscious or trapped in a fire. Prolonged exposure leads to more extensive damage, increasing the risk of shock and secondary complications. Burn injuries compromise the skin's protective barrier, leading to an increased risk of infection, hypothermia, hypovolemia, and shock. Managing these complications is a primary concern in burn care. Burns affecting the airway pose significant threats. Circumferential burns around the chest can restrict breathing, while burns on an extremity can lead to neurovascular compromise and tissue death if swelling is not managed properly. The severity of a burn is determined by its depth, extent, location, and the patient's overall health status. Critical areas include the face, airway, hands, feet, and genitalia. Young children and older adults are more vulnerable to complications. First-degree burns involve only the epidermis and cause redness, but no blistering. Second-degree burns affect the epidermis and dermis, leading to pain and blistering. Third-degree burns extend through all skin layers, appearing dry and leathery. Burns are often classified using the rule of nines, which estimates the total body surface area affected. This method helps determine fluid resuscitation needs and overall treatment strategies. Initial care for burns includes stopping the burning process, cooling the affected area, and preventing further injury. Keeping burns covered with a dry, sterile dressing can help prevent infection and maintain body temperature. In addition to depth and extent, other factors influence burn severity, such as inhalation injuries, associated trauma, and pre-existing medical conditions. These considerations help guide treatment priorities and long-term prognosis. Patients with extensive burns or burns involving critical areas require specialized burn care. Rapid transport to a burn center is recommended for patients who meet criteria for severe burns. Early intervention improves outcomes and reduces complications. When assessing a burn patient, classification is key. Consider the source, depth, and severity of the burn. Assess for signs of airway compromise, inhalation injury, or associated trauma. A thorough evaluation ensures appropriate treatment and transport decisions. Initial care for burns includes stopping the burning process, cooling the affected area, and preventing further injury. Keeping burns covered with a dry, sterile dressing can help prevent infection and maintain body temperature. Thermal burns are the most common type of burn injury and result from exposure to excessive heat sources such as flames, hot liquids, steam, or hot objects. The severity of the burn depends on the temperature of the heat source and the duration of exposure. There are different mechanisms of thermal burns. Scald burns occur when the skin comes into contact with hot liquids or steam. Flame burns result from direct exposure to fire. Contact burns happen when the skin touches a hot object, while flash burns are caused by exposure to a sudden burst of intense heat, such as an explosion. Management of thermal burns includes removing the patient from the heat source, cooling the burn with sterile water or saline, and covering the area with a dry, sterile dressing. Avoid using ice or applying ointments, as these can worsen tissue damage. Severe burns require rapid transport to a burn center for specialized care. Inhalation burns occur when a patient breathes in superheated gases, smoke, or toxic fumes. These burns can cause severe damage to the airway, leading to swelling, obstruction, and respiratory distress. Burns in enclosed spaces increase the likelihood of inhalation injuries. Severe airway swelling can occur quickly following inhalation burns. Signs include hoarseness, singed nasal hairs, soot around the mouth and nose, and difficulty breathing. Advanced life support, ALS, backup should be considered in cases of suspected inhalation injury. Inhalation of toxic gases, such as carbon monoxide or hydrogen cyanide, can be fatal. Carbon monoxide poisoning presents with headache, dizziness, nausea, and cherry red skin in severe cases. Cyanide exposure can lead to rapid respiratory failure. Administering high-flow oxygen is the first-line treatment. Management of inhalation burns includes ensuring scene safety, removing the patient from the hazardous environment, administering high-flow oxygen, and monitoring for respiratory distress. Patients with severe inhalation burns should be transported immediately to a specialized burn center for further treatment. Chemical burns occur when toxic substances, such as strong acids or alkalis, come into contact with the skin. These burns can cause extensive tissue damage and require immediate intervention to prevent further injury. The eyes are particularly vulnerable to chemical burns. The severity of a chemical burn depends on the type of chemical, its concentration, and the duration of exposure. Alkalis tend to penetrate deeper than acids, causing more extensive damage. Wear appropriate personal protective equipment when treating chemical burns to avoid secondary exposure. The first step in managing a chemical burn is removing any remaining chemical from the patient. Dry chemicals should be brushed off before irrigation. Liquid chemicals should be flushed with large amounts of water for at least 15 to 20 minutes. If the burn involves the eyes, continuous irrigation is necessary. Proper decontamination is crucial before transporting a patient with chemical burns. Ensure the patient's clothing is removed if contaminated, and monitor for signs of systemic toxicity. Prompt transport to a hospital is recommended for significant chemical burns. Electrical burns occur when the body becomes part of an electrical circuit. The severity of the burn depends on the type of current, voltage, and pathway through the body. Electrical burns often cause deep tissue damage that may not be visible on the surface. The human body is a good conductor of electricity, meaning electrical burns can cause widespread internal injury. Cardiac arrhythmias, respiratory arrest, and muscle contractions leading to fractures are common complications of electrical injuries. Burn injuries from electricity often present as an entrance and exit wound, with extensive internal damage in between. Patients may require advanced cardiac monitoring due to the risk of arrhythmias. Scene safety is a priority when responding to electrical burn patients. Do not touch the patient until the power source is shut off. Ensure that high-voltage injuries are handled with caution and involve specialized rescue teams when necessary. Emergency management includes CPR if indicated, application of an AED if necessary, and administration of oxygen. Soft tissue injuries should be covered with a dry, sterile dressing, and the patient should be transported promptly for further evaluation. In recent years, law enforcement agencies have increasingly used tasers to subdue individuals. While taser-related injuries are generally minor, they can still pose medical concerns, especially in individuals with underlying heart conditions or those under the influence of stimulants. Tasers deliver an electrical shock that can cause temporary paralysis and muscle contractions. In some cases, patients may experience burns at the electrode entry points, dysrhythmias, or even sudden cardiac arrest. EMS personnel should always assess a tasered patient for underlying conditions that could complicate recovery. Radiation burns can occur in a variety of situations, including incidents involving radioactive isotopes and intentional radiation exposure, such as in terrorist attacks. The first priority in managing radiation burns is to determine whether the patient is still being exposed to radiation and whether ongoing exposure poses a threat to first responders. Proper decontamination and safety precautions are essential to minimize further harm. There are three types of ionizing radiation: alpha, beta, and gamma radiation. Alpha radiation has little penetrating power and can be stopped by the skin. Beta radiation has more penetrating power but can be blocked by simple protective clothing. Gamma radiation is the most dangerous as it can penetrate through the body and solid materials, requiring significant shielding to prevent exposure. Most radiation-related injuries involve gamma radiation, such as those seen in X-ray exposure. In these cases, maintaining a safe distance is critical while waiting for the hazardous materials, hazmat, team to decontaminate the patient. Once it is safe, emergency medical care should focus on addressing life-threatening conditions using the XABCs: exsanguination control, airway management, breathing, and circulation. Open wounds should be irrigated thoroughly to remove potential radioactive contaminants. Management of radiation burns includes notifying the emergency department of the patient's exposure, identifying the radioactive source, and limiting responders' exposure time. Increasing distance from the source and using proper shielding are key safety measures. It is crucial to document the duration of exposure and the type of radiation involved, as this information will guide further treatment and decontamination procedures. All open wounds require dressing and bandaging to control bleeding and prevent infection. Splints can also provide firm support for dressings and help stabilize injuries. There are different types of dressings used for wound care, including universal dressings, gauze pads, adhesive dressings, and occlusive dressings. Selecting the appropriate dressing depends on the wound size, depth, and severity. Dressings and bandages serve three primary functions: controlling bleeding, protecting the wound from further damage, and preventing contamination and infection. Using the correct dressing technique is essential for wound healing. In cases of severe bleeding, direct pressure should be applied, and if necessary, a tourniquet should be used as a last resort. Most wounds will require sterile dressings, including universal dressings, for X4-inch and 4x8-inch gauze pads, small adhesive-type dressings, and soft self-adherent roller dressings. Universal dressings are especially useful for large wounds, while smaller gauze pads are appropriate for minor injuries. For minor wounds, adhesive dressings provide sufficient coverage. However, in more serious cases, occlusive dressings are used to prevent air and liquids from entering or exiting a wound. This is especially important for injuries to the chest or neck, where air embolisms can be life-threatening. Bandages help secure dressings in place during patient transport. The most commonly used bandages include soft roller bandages, gauze rolls, triangular bandages, and adhesive tape. Soft roller bandages are easy to use and provide secure coverage without restricting circulation. Adhesive tape is useful for securing smaller dressings and ensuring larger dressings stay in place. However, elastic bandages should not be used to secure dressings, as they may act as a tourniquet, restricting blood flow and causing additional tissue damage. Splints are particularly valuable in managing broken extremities. They provide stability and can also help control bleeding when used in combination with dressings. If direct pressure and dressings fail to control severe bleeding, the next step is to quickly apply a tourniquet to prevent further blood loss.